Oh, there's good one.
All right. Well, good morning, everyone. Great to see everyone. I know it's a very busy time of the year, and finding a whole day to block off is not easy during this time period, but I really do appreciate you carving out this time to be part of our Texas Child Mental Health Care Consortium work. A lot of exciting things are happening. We're getting ready for the legislative session. Again, great work across all the institutions. I'm hearing wonderful things that are occurring at your institution. So again, thank you for the ongoing commitment to improve care for kids in the state of Texas. So with that, Luann, why don't we go ahead and take our formal roll call?
Good morning, everyone. I'm going to do the roll call. Uh-oh, am I echoing? Okay, Bobato.
Here.
Blader.
Here.
Castle.
Here.
Chapa. Farmer.
Here.
Gaines. Goodman.
I'm here.
Harper. Ibrahim.
Here.
Keller.
Here.
Lakey.
Here.
Liberzon. Martin.
Here.
Martinez.
Present.
Mayor. Mitchell.
Here.
Nemiroff. Newport. Nichols.
Here.
Patriarca. Pliska.
Here.
Podewelts.
Here.
Robert. Schlacklin. Suarez. Taminga.
Here.
Ton. Thompson. Vo.
Here.
Wagner.
Here.
Wakefield. Wesley.
Here.
Williams.
Here.
Johnson. Okay, that's it.
How many do we have?
Here. Johnson's here. Sorry.
Wakefield is here as well. 22.
All right, we're at 22, so we are officially above quorum, so we can go ahead and begin. Again, appreciate everyone being here today. I think this meeting, I don't think we'll use the full time period that we've allotted, but again, appreciate you being available. So the first order of business, we need to approve the minutes from the last meeting on October 25th. Please take a quick look. If you have any questions, suggestions, please let us know. Otherwise, we'll take a motion to approve in a second.
So moved, Dr. Ibrahim.
Second.
Second, I have a motion and a second. Any further discussion? Hearing none, all in favor of approving the minutes signify by saying aye.
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 Opposed, nay? Is there anybody that abstained? All right, they are approved. Second order of business. It's entitled Discussion and Take Appropriate Action for the Texas Educational Agency to serve on the executive committee. So let me give you a little bit of background on this one. According to our bylaws, we are allowed to add individuals that we think would be important for the work of the Mental Health Care Consortium. We believe that, the reality has been over the last several years, we've been working very closely with the Texas Educational Agency, and they have been an essential partner in the work that we're doing. Over the last half a year, this has become increasingly important, obviously after Uvalde, to make in the direction that we've been given to make sure that TCHAT is in all the schools that want it in the state of Texas. So with that, we think it would be nice to more formalize their role as part of the Texas Mental Health Care Consortium and actually have a slot on our executive committee for the Texas Educational Agency. So want to start off there, and we have a couple of people from TEA that have joined us. They may want to say a few words, but first, the general concept, is there any questions about that before I introduce one of our guests that's here today? Okay. Seeing none. John Scott, I saw you a little bit ago. You want to introduce yourself? I had the pleasure of meeting Mr. Scott several months ago, and he's going to have a key role at TEA related to a variety of issues. And so, Mr. Scott, I will turn the virtual podium over to you for a minute.
Thank you, sir. Hi, my name is John Scott, and I'm the new Chief of School Safety and Security within TEA. Thank you for inviting us here today. I know that I'm not saying anything everybody here doesn't know, that the child mental health is a very, very important, vital part of school safety. So that is how we want to partner with you guys. We want to be partners with you, and I think that we can help each other. Obviously, you help us more, probably much more than we can help you, but we need you, and I think that is a vital part. So thank you for giving me a little time to introduce myself, and I look forward to working with everybody in the near future.
And Julie Wyman, I think you also have joined us today, right? For those of you that haven't met Julie, she has been our champion at TEA for the last several years and has been a champion at the legislature for her work. And so, Julie, anything you want to say as we start?
I was just asked to be here and to help back up John and TEA. I work in the Supportive Schools Division at the agency, director of our mental and behavioral health coordination work in supportive schools. While John is leading our whole school safety work, we kind of have a safety and a support division. And so just here to keep working with Luann, Dr. Wakefield, Williams. We've all worked together over many years to help kind of get this going. And it's very important to get T-Chat into every school. That's certainly our vision as well. So thank you. And I'll be here to back up John and support all of y'all. Thanks.
Very good. Again, really do appreciate the partnership with TEA over the last several years. We couldn't have done this without your help. So thank you very much. Any questions from the executive committee? And if there's not, then I would need a formal motion from one of the executive committee members to add a position to the executive committee for the T. Move for approval.
Yep. Second.
Okay. I heard a motion from Alan and a second. I'm not sure who gave the second.
Isham. Ibrahim.
Isham. Okay. All right. All in favor, signify by saying aye.
Aye.
Any opposed, signify by saying nay. Hearing none, anybody abstain? All right, we have unanimous approval to add the TEA to the executive committee for a position, an individual selected by their commissioner, and that is John Scott. And so, John, I really appreciate you joining us today and being part of our work. So thank you.
Thank you, guys. And again, I look forward to working with everybody. Thank you.
All right, very good. Let's next go to item number 4. Actually, before I do that, there's been several people that have joined us since we did official roll call. If you joined us after we did roll call, would you please let us know that you are here?
Israel is here, Israel Liberson.
Okay, Israel, great to see you. And Danette Castle, I don't know if she, we had Danette earlier. Okay, great. Anybody else?
Jair Suarez, I joined a little late.
Hi, Jair, good to see you.
Good to see you too.
All right. Let's move on then to item number 4, the presentation on the Children's Crisis and State Hospital Needs Survey with our partners from HHSC. Dr. Swanee, I saw you here just a little bit ago, and I'll turn the virtual podium over to you.
Great. Thank you all for having us here today. You all can see my PowerPoint, my slides.
Yes, we can.
Great. So my name is Rishi Sani. I'm the Community Behavioral Health Medical Director here at HHSC's Mental Health and Substance Use Programs. And I have Will Terry from my team here because he had helped with a lot of the work. So if there's any questions in particular. But we are really excited to be here today because we at HHSC we're looking at the needs for children in terms of state hospitals. But when we started doing that work, we also wanted to make sure we understood the whole system as well. And so we took it upon ourselves to put together a survey, which we distributed very widely throughout the state. A lot of you all helped distribute it, so thank you for your help. The Federation of Texas Psychiatry had submitted it to all their members. It went to people in juvenile justice, state hospitals, community providers, advocates, and so we were excited about how many people had filled out the survey. And the point of the survey was to also make sure we understood what are the needs and maybe gaps of our state in terms of outpatient and crisis services that might decrease the need for state hospitalization. And so today, our hope is to present the voice of all the Texans that have filled out this survey. So that way, all of us can get a sense of where Texans feel like services need to be prioritized. So we had conducted the survey and completed earlier this year in January. We had 661 full respondents. 620 were what we call other stakeholders, basically anyone that wasn't either a child or family member with lived experience. And one of the first questions that we had talked about or started with was, does the state need increased capacity at state hospitals for children in particular? And there's an overwhelming majority that said, yes, there needs to be increased capacity at state hospitals. And this is something that we had heard been looked at and discussed in the past, many years ago. And the picture's a little bit different today as there's less facilities that accept children. But at that time, there was not as much interest or thought that there needs to be more room for children at state hospitals. That being said, this next slide puts it into context in terms of what the priorities people feel like are for children. So when you look at this, we ask people to say, of different service types, which service type do you think we need to make sure there's more access to? And though most people want state hospital access, they wouldn't rank it as the highest priority. A lot of people chose other services that need to be prioritized instead in terms of expanding access. And we also have a lot of different breakdowns of this data, like urban versus rural or family members. But with our time today, we're going to just focus on this other stakeholder group responses for today. So the thing that people wanted most was specialized counseling programs, which we just defined as programs that are there to treat a specific diagnosis and a specific issue, and can include things like eating disorders, programs that address that provide dialectical behavior therapy for budding personality issues, and multi-systemic therapy programs. And so though a small amount of children might need specialized counseling programs, this was the clear overwhelming favor for what kind of programs people felt were needed in our state, and family members also agreed. And then some of the other things that we saw were things in the in between hospitalization and outpatient care. So intensive outpatient programs, crisis respite, children's mobile crisis outreach teams, residential treatment centers, and crisis residential. And I will point out that a lot of these don't have ways of funding in our state through Medicaid or other ways. And HHSC recently funded for children's crisis respite over this last summer, but a lot of these specific programs don't have a billing mechanism, reimbursement mechanism, at least in the public mental health system, for them to be available. And then in terms of what specific services do people need more access to, there's a clear interest in that then there's difficulty accessing counseling and family therapy services. And so this is something I meet with the LMHA medical directors, local mental health authority medical directors. They say this is also their biggest gap in terms of hiring, is finding people that can do therapy with children that are trained, knowledgeable, available is challenging. And that's what the field felt as well. There's also this interest in crisis services, case management, and med management. And then interestingly, I think there's not a lot of people that might fit under in the justice system, but there's still a lot of interest in mental health justice diversion programs for children in particular. Families really rated highly the need for getting psychological assessments as one of the places that we would be expanded upon. We wanted to understand also what barriers people felt were the most common barriers to getting mental health care. And a lot of people have mentioned this lack of timely access to services, not knowing about services. And then another thing that came up was just the cost associated with mental health care limits access to people that can't afford it. And then I'm glad TEA is here too, because there's also this interest in mental health services in public schools as well. One thing that was a little bit surprising was not a lot of people felt like not having telemedicine was a big barrier to care. This is also common amongst family members as well. And there were just other barriers that were higher, seen as bigger barriers to care. This was also done during COVID when telemed, audio only, especially, was probably at its highest point. We also wanted to understand for inpatient care, where can the state hospitals be most effective? What areas might it make sense for state hospitals to target, or if there's other options that we can support in the community as well for inpatient needs. And it seemed like this is noted is that getting inpatient care for children younger than 13 in particular is very difficult. A lot of places separate their under 13 and over 13 population, and a lot of places just take over 13. And so finding a place for inpatient care for those younger children is even harder to find in our state. And then having facilities that will serve people with physical aggression, longer hospitalization, and people who do not have any mental health or coverage or insurance. Even though a lot of children have access to insurance due to Medicaid, there's still that gap for some of those children as well. And then we saw some of the co-occurring disorders that are common in inpatient care that might be harder to find inpatient services for children with IDD or autism as well. We also asked about how possible it was to access state hospitals before the COVID pandemic. So we felt was during the pandemic, we felt like there's a lot of things that might be misleading if we just asked about now. So we wanted some past information. And based on that, those results, we see that 2% said they could access it with ease, state hospital services, but 23% said they were able to access it, and then 17% unable to access, and then 25% without with great difficulty. But after the pandemic, we see that falls to 1% with ease, able to access went from like 17 to 11%, and then unable to access the state hospital services when they went up, and more with great difficulty as well. So there's a lot of things that happened in the pandemic. Facilities were closed, staffing levels were low. Some hospitals had already been closed. So just something that we noticed as well. I know Dr. Matthews and I have done a lot of data analysis on the state hospital side, and he said he'd be happy to present to you all and see you all again. He had a lot of fun on this committee beforehand. So he is available if there's more you want to talk about, specifically on the state hospital side. In the survey, we also got a lot of qualitative answers, and people provided some great feedback for us about what are some places where we need services, what are some barriers and some issues. There's some heartbreaking stories clearly as well with people trying to access care. But I wanted to highlight these in particular. So there's in terms of what's needed, wraparound, a lot of emphasis on the community resource coordination groups, CRCGs, for every county. They help staff people that have higher needs and make sure the community needs are being provided to children with higher needs. And then this in particular came up, which I thought was relevant, ended up being relevant for today, more TCHAT and CPAN access as well. And then treatment centers that work with limited or health or no health insurance, having this crisis stabilization and maybe med management on demand instead of waiting for an appointment. And then again, this emphasis on this in between outpatient and inpatient, with wanting access to IOP, partial hospital programs, trauma-focused CBT, wraparound services, yes waiver. Yes waiver is actually one of the things that families specifically prioritize as needing more access to. And then I am a psychiatrist, but I thought this was also very poignant. It's what we've heard from the field as well, is just access to therapy. I've noticed that when children are on medications, the focus is often on the medication and there's little attention on ongoing therapy and prevention. So that was a quick summary of our survey. And there was a lot of great data out there. We presented it to a few groups, and so far people feel like that seems to be an accurate reflection of their experience with children and what the needs are. But I'm happy to answer any questions, or if anyone else wants to say, this is what we feel, either similar or different, I'd just love to hear from you all.
Very good. Thank you, Dr. Swanee. I see a hand from Dr. Goodman. Wayne?
Yeah, Rishi, good to see you. A great presentation, very informative. I have a couple of methodological questions, and you may have covered them, and I just wasn't paying attention closely enough. Of the people you surveyed, the 620, could you tell me a little bit about them? And also in the different categories that you showed for various questions, were they pre-populated so and so that people have a menu of choices, or was it more free form? And then, and the second part of that is that could they choose more than one option?
Yeah, so in terms of the questions, they were the answer choices for like barriers, what services need to be prioritized, what services need to be expanded upon. Those questions had pre-populated answers, so all the answer choices were up on the slides. And then depending on the question, it was either they could choose 3 or 5 options of all the options. We were thinking about a ranked order, but that was a little bit too complicated for a public survey. And then in terms of the respondents, I can see if Will Terry can come on and give us the percentage breakdown. I think it's about 60% community mental health providers. But Will, are you able to expand on that?
Absolutely. Glad to be here. My name is Will Terry. I'm a clinical social worker, and I work with Dr. Sani and helped on this initiative. As far as the percentages of the respondents, we had 372 respondents who were community health providers, so about 44%. 14% of the respondents were school providers. 13% specified that they belong to another state agency. 7% were mental health advocates. 6% were family members of children under 18 who had accessed mental health services in the past 5 years. 3.4% were Texas Juvenile Justice Department employees. 2.9% were state hospital psychiatric providers. 3% were employees of the Department of Family and Protective Services. 3% were private psych hospital providers. 2% were primary care providers. 1% were law enforcement officials. And less than 1% were folks who had accessed mental health services as a child under 18 in the past 5 years.
And how many did you send out to originally? You know, what kind of what's the denominator with the 620 numerator?
That's a great question. We had a lot of different groups send out the survey on our behalf, so I don't have a great denominator. It's everyone, we asked everyone to share.
Okay, thank you.
it was a public survey. It wasn't specifically targeted in other ways.
Any other questions? Jeffrey? Thank you for that presentation. One of the things I noticed in the survey results of the barriers and you highlighted that only 77% reported that lack of access to telehealth was a problem. But at the same time, 44% said that lack of transportation to and from visits was problematic. So help me reconcile those two.
I think that's a great question. I think that's where telemedicine does fill some of that gap. I think there is children that this is my interpretation of the results, is there are children that really benefit from in-person care and being seen in that kind of setting. And then for a lot of the programs like intensive outpatient, partial hospitalization, you need to be able to send someone there every day to go to. And so our reimbursement accounts for the care, but a lot of our population might not have the ability to take off time to go to these appointments, especially if it's every day for a week. In particular, is the way I made sense.
Thank you. Luann?
Hi, Dr. Sani.
Hello,
Hey,
Ann.
just a quick question for you. If you could let us know, how will HHSC be using this data and information in terms of planning for the future?
So this has been presented to a lot of our leadership. Both Deck Shacklin and Deck Games have seen it. And there's a lot of work being done in terms of preparation for the session. So this is just one of the places they can have extra information in terms of prioritizing needs and gaps and having data that shows the needs.
That was actually going to be my question. Is kind of the next steps with this data and how it impacts the conversation during the legislative session. It seems like there's several things that are aligned with what we're doing and trying to expand TChat and CPAN. It seems like one of those other natural questions is, if you're going to increase inpatient capacity, where do you do that? And the question of state-run facilities or HHSC over the last decade and a half, even when I was at DSHS, we started moving more towards community beds and purchasing beds versus the state facility beds. And so it'd be interesting to hear how that flavors your conversation as things move forward in the next several months. Danette, I see your hand.
Yeah, so I was just thinking, and Dr. Lakey, actually, you made me think of another point since I even raised my hand. So in follow up to what you were talking about in terms of inpatient, I think just to affirm the need to address specialized inpatient beds for kids, whether that is in state hospital or in purchasing services through community hospitals, and how important it is for us to recognize that in terms of thinking about specialized beds, it's not going to be a typical purchase, right? So it's not going to be a typical by bed day purchase, because you're really asking those community hospitals, if in fact you're relying upon them, which in many areas of the state we are, how important it is for the state to recognize that the mechanisms by which we can purchase locally those beds needs to be really established in such a way that allows for a hospital to develop a specialized service. Is going to be a bit more expensive, that probably requires them to develop a unit. And that purchase may need to look different. That is an issue that we have talked about with the agency. I know that there's a lot of interest and conversation about it right now, even as the base budget bill is unfolding, but we're hoping to see some flexibility in terms of the purchasing for those services, as well as to see some specialized services develop out of the state hospital system. Happy to see that Dallas is looking to develop some kids services there for the new hospital. That's really important. And then just to say, Dr. Sani, I hope in follow-up to the question about that Luann posed about what is the state agency doing, you see running through those responses challenges about the workforce, like workforce challenges, ability to find practitioners, counselors, where you see gaps. Some of those gaps are driven by the fact that we're not competitive in the workplace now. And Dr. Lakey, you've made this point in a number of hearings about how important it is for us to address those workforce challenges. The state agency does seem to recognize that challenge when it is in its exceptional items or in its LAR, recognizing the need to put additional resources in for state facilities. We're hoping that when the next round of the mental health plan actually comes out, there will be some focus on community as well. We're concerned there may not be. And if there's not, we all really need to raise a voice on that, because it is, if we don't have the funding to be competitive in the marketplace for the practitioners that we need, for the staff that we need, qualified mental health professionals are one area where we're really short and they're an important component. But we'll need to raise our voice if we don't see the agency coming out or the base bill coming out with a recognition that workforce and community is every bit as needed in terms of resource investment as compared to the state facilities.
Very good, Danette. Thank you. Andy, Dr. Keller?
Yeah, thanks. So really interesting survey, Rishi. Thanks for sharing it. You know, you mentioned several times some of the breakouts by different subsets of respondents. Will you all be sharing those crosstabs? And maybe there already are, but I mean, I know there were several documents sent, and if they were already sent, but I would encourage you to do so, because I think our ability to support you all using them and talking to people will be much more empowered if we can sort of talk about those differences as opposed. I mean, the aggregate information is interesting, but I think it would be more useful if you could include the crosstabs.
We can do that. And then if there's a way you want us to look at the data, we can also be happy to talk to you about a different way to slice the survey results.
Very good. Dr. Ibrahim?
Yeah, I mean, I agree with everything Danette said. The only thing that I want to add is as we look into really having specialized services in the state hospitals for some of these patient populations that have been highlighted by the survey, which is really a real need, autism spectrum disorder, intellectual disabilities, aggression, without an actual concerted effort between the state hospital and the LMHAs to really create wraparound services and step-down services, we're not going to be able to move it forward. Meaning, we could create units, but these units will be quickly filled. They will become the proxy residential places for these patient populations. And that actually will not help us with the rest of the capacity we need to provide for kids. So I do think that there is an opportunity to really, the Dallas hospital is certainly considering, having specialties. They will have it on the adult, on the peds side, we're in the middle of programming, but we do need to have that kind of engagement so that we're really kind of thinking about the system as a whole and how we can come together to create something that actually would be functional.
Very good. Dr. Blader?
I think it's wonderful that we have a TEA representation here because kind of cues up the thing that always comes to mind for me, which is if we're going to be getting serious about having an appropriate quantity of day treatment services, they have to be linked with appropriate school program. So I hope that that's part of your agenda moving this forward. And maybe this group can help catalyze that type of collaboration, which is going to be so important programmatically going forward.
All right, very good. Dr. Martinez.
Rishi, great presentation. Is there, I know it's 620 respondents. I don't know if you're able to disaggregate the data to see if there's any disparities, not only but from a racial ethnic perspective, but even just geographic across the state of Texas, because we're such a huge state geographically, and what may be needed in West Texas may be looking very different from East. And I don't know if you're able to, like I said, disaggregate and do that type of analysis, or at least pull out those maybe kernels.
Yeah, thank you, Octavio. Great question. We didn't collect race or ethnicity information on the survey, and I think that it's important to recognize we don't know if this is an accurate demographic representation. based on who filled it out in terms of race and ethnicity, also very important to make sure. And then I think we had maybe it was about 60% rural respondents, and then like 40-something% urban. We use the All Texas Access County breakdown for rural versus urban to categorize that. And then they've asked us to look at a few rural counties that they're working at to look at the data for those areas. That being said, once you go into those rural counties, the numbers are a lot lower as you get into specific county kind of data. So we asked everyone to fill out the county that they either provide services in or access services in.
All right, very good. Well, first, thanks everyone for that robust discussion. I think that's the value of the consortium is we can present this information and get real-time feedback. And again, Dr. Swanee, thank you. And we look forward to hearing what happens next and how that flavors the conversation this next legislative session. So thank you so much for being part of this conversation today.
Thank you so much for having us. We're so happy we could share it with all of you in particular. So these results, the voice of people wasn't just something we heard, but everyone could see was how people felt about our services.
Very good. We will now move to item 5 and have the updates on our evaluations. And we'll first go to Dr. Lopez and David Lynch.
Hello, everyone. So we do not have a PowerPoint today. We're just going to share some quick updates about some of the work that we're doing and be really brief. So one of the things we're doing is finishing up our year-end report to document all of the great work that happened last year. And we really are looking forward to being able to kind of pull together a brief infographic report like we did last time that we'll bring to the executive group to review and suggest any changes and hopefully approve when that's ready to go out publicly. We want to take just a quick second to thank the incredible hard work of your TChat teams as all of the teams have been challenged to expand and offer TChat to all public schools across the state. We know that's a really significant task, and we're seeing a lot of progress happening in that world. So we appreciate the regular feedback that teams are needing to provide us so that we can provide that feedback more broadly, and just really want to appreciate all of the work that the teams are doing to make that goal a reality. One of the things that is a follow-up from last meeting is that TRAIT is building the Columbia Impairment Scale that we talked about last time into the system for TChat students in order to give us a new strategy to measure children's functioning over time. And the teams are meeting to talk about kind of how to standardize the use of that scale so that we can have both a tool that's going to be supportive to the teams in their measurement-based care and also a nice measure to look at the impact of the services that are being provided. So that is progressing well. On the CPAN side, just a quick update. David has been meeting with a number of states who have similar access programs to just discuss different ways that they are evaluating their programs to see if there's any good ideas or metrics that we can learn from and be able to do a little bit of benchmarking across the different states. He's going to continue to do that as he kind of hears back from the different states that he's reached out to. And then just another quick update, sort of the exciting place that we are with PeriPan, that there is early data now available. And so David, as our lead on that, is exploring that data, doing that work to identify any early issues that are seen in the data to help clarify those early so we can make sure that we've got really strong, good data coming out of PeriPan for sharing and evaluating that. So that's kind of the things we've been working on, and excited to hear from anybody if they have any questions or anything else they'd like to know.
Very good. Thank you, Dr. Lopez. Any questions for Molly? All right, seeing none, and I'll talk about this a little bit later, but thank you again, Molly, for your ongoing support for the LBB report that we put together and the work that we're doing to make sure key legislative offices are up to date with the expansion of TCHAT. So again, really appreciate your partnership in this. So thank you. All right. Let's go next to Dr. Savas and her team at UT School of Public Health.
Hi, this is Melissa Peskin. I'll be doing the presentation today. Thank you. Can everybody hear me?
Yes, we can.
Okay, great. So today we just had a few slides. We wanted to highlight some of the qualitative work that we've been doing with our external evaluation. But I also just want to echo Molly's remarks about our thanks to everybody for all their support and participation in all of the evaluation activities over the last several months. And then we are also finalizing our report as well. And these findings will be included in those. So if you want to go to the next slide. So one of the components of our evaluation was to interview the CPW fellows. So the overall goal here was to describe CPW fellows' experiences, particularly as they relate to the strengths, challenges, and impacts of the CPW program. And we conducted in-depth interviews with 11 CPW participants, 6 residents, and 5 fellows that were representing 10 different HRIs as part of this year 2 evaluation. 2 HRIs did not have current or residents or fellows, so they unfortunately cannot be represented in this evaluation. And I also just wanted to mention that the implementation, as we know, of the CPW program is still in the early stages, so it will take time, of course, to see the full impact. But these findings have shown some early indicators of really great progress. So regarding expanding the mental health workforce in Texas, one of the fellows said, it's actually one of the things that brought me to the fellowship, having those multiple options, community reach options, which many programs still don't have across the country. And having that wide exposure to populations and settings was one reason that I chose this fellowship. Next slide. The CPW training did not impact participants' future career plans directly, is what we heard from them, but really generally contributed positively to reaffirming their career decisions or expanding their thinking about career options. So one of the quotes, the diversity of the population that I saw definitely changed my perspective on what I really wanted to work on and do, not just the outpatient or inpatient settings, but even the population that I want to work with. At this point, still deciding, but I'm leaning more towards community practice. And we also received some feedback about how the fellowship helped prepare them to interact with diverse patient populations. And one of the fellows did mention that the program, or many of the fellows mentioned that the program did offer exposure to diverse patient populations, and it has really helped them to prepare them for cross-cultural interactions and culturally responsive mental health care. One fellow remarked, I just feel they're so deserving with the services and support, and they're receptive. You feel like you're part of the solution, and you feel like progress is being made. You learn so much about people and their cultures and their perspectives and their motivations. That definitely is rooted in a community mental health experience more than any other psychiatric rotation experience. So really a positive remark there about interacting cross-culturally. Also found that the CPW program has built the capacity of participants to serve diverse patient populations. The pathologies, the diagnoses I see in these individuals are very wide-ranging. It's rarely the same thing twice. I see a lot of individuals with different diagnoses, have different assessments, and because of that, I've used a lot of different treatment modalities, and that has helped me to learn more about the future. There were some areas of improvement that participants also identified, and that largely reflected the challenges they experience, which were perceived differently by residents versus fellows. Residents would like to see improvements to supports and resources, enhanced learning opportunities, and more in-person visits. One resident remarked, "I'd like for all the patients to have to come in person, but I don't think that that's unique to the CPW program." And fellows would like the program to consider how time limitations at rotations could be addressed to the extent possible. "We hate to have to change every 2 months. The patients lose hope because every time they get there, it affects rapport and it affects compliance." Next slide. So we also just wanted to draw attention to some of the qualitative work with our CPAN and TChat survey. So as a reminder, we distributed a survey to CPAN providers over this last year. We received responses from 97 providers. Many of them remarked on the benefits of the CPAN program. 95% indicated that accessibility to psychiatrists for quick and direct access to consultation services, information, and resources was the greatest benefit. Several respondents mentioned that CPAN has increased their confidence in treating pediatric patients with mental health needs. Many of the providers also noted some barriers and some improvements that could be made to the CPAN program. The greatest barrier was time constraints for making calls. It was perceived as a disruption of workflow and required additional time built into schedules. To a lesser extent, there was some mention of a lack of buy-in and support at their clinics and the program not meeting their needs were reported as barriers, and some frequently mentioned areas for improvement included improved outreach and awareness, more implementation support and training, and improved connections to community resources and referrals. And then finally, for TChat, if you go to the next slide. Next slide, please. Okay. We received respondents for about 197 individuals who are involved in the TChat survey from school districts. Vast majority indicated, which is what we saw last year as well, that indicated that accessibility of care for underserved students in need was the greatest benefit of the program. And many respondents mentioned that TChat provides a level of mental health care to students that cannot be provided by school counselors alone due to specialized needs and time constraints. Some frequently mentioned areas for improvement included the desire for more efficient and streamlined paperwork systems, better communication and follow-up, more training, more flexibility in scheduling students, and additional sessions for students. And many also remarked on some very positive feedback about the program and its impact on the students. And I think that's it. Any questions?
Very good. Thanks, Melissa. Great feedback. Any questions from the executive committee? Sarah Martin?
Hi, and one thing I wanted to mention just for the benefit of the audience, and then also for the people who don't work on the executive committee that don't work directly with CPW, is that I think it really increases job satisfaction of the faculty, which is super important because we aren't totally competitive with private practice and things like that, but this really, I think, adds to the meaning of our jobs, gives it a deeper meaning. And then also it adds variety, which I think goes a long way to keep people that we already have, but then also to attract people who maybe have a job that is, doing the same thing every day. So anyway, I just wanted to mention that because I just love this program so much, and it's just added so much to my enjoyment of my job.
Thanks, Sarah, for that feedback. And I found it interesting that you actually had a fellow say that was part of their selection to come here to the state of Texas and one of your programs is because they could be part of this program and that diverse patient population they serve. And it's impacting their career choices, it looks like. So yeah, thanks for all the hard work from everyone across the consortium to do that. Any other comments or any other questions? All right. Well, thank Dr. Peskin and Melissa for the not only the presentation, but the ongoing evaluation and helping us sharpen our game. That feedback is really helpful, and we'll take that constructive criticism back and we'll figure out how do we improve the program. So really appreciate it. Thank you. All right. Why don't we go to item number 6? And Linda, we'll start off with you with the update from the fiscal agent with
Good
the ARPA
morning.
funds.
Yeah,
Yeah.
thank you.
Good morning.
I'm happy to report that we have received all but one executed agreement, and that one should be arriving soon. So we're off and running with all the contracts. And we're also processing now some amendments where folks needed some additional funding that we have available as well. So we're excited that these things are moving along. We've also received about $2.2 million worth of reimbursement requests that have come through. So we have been processing those as well. And so about $1 million of that comes from the CPAN program, and just slightly over 1.1 million in the TCHAT program, and then around $110,000 in the workforce expansion portion is what the numbers have come to us for. So we know that's a small amount out of the whole 109 million that we're responsible for, but it's exciting that we have that part of it working. And we anticipate that each of the HRIs will be sending us invoicing each month now. So that's what we have.
It's good to see that the money is being spent.
Yes,
And,
it is.
so
It's exciting.
good. Any questions for Linda? All right, seeing none. Let's go to the overall administration update, UT system. Michelle, I'm going to jump in first. I think there's a couple things that are going on that it would be good to update everyone about. You know, the main thing is we're trying to get ready for the legislative session. And so we've had a series of meetings with key offices, making sure that they understand the needs that you have and the desire to expand the services in the ways that make sense. We've had a lot of conversations with them related to what it's going to take to put TCHAT in all the schools that want it here in the state of Texas. And thus far, I've been getting a lot of good support. Again, they're working on their base bill right now, and we're hoping to influence that as we have these conversations to get some of these needs addressed. But those conversations are going well. We have ongoing dialogue with those key offices whenever they have a question to make sure they feel very comfortable with what we're trying to do and that we're in alignment with the direction that they've given us. But thus far, they're very supportive of the work that you're doing. It's been very helpful that they're hearing from the superintendents across the state of Texas that what you're doing is very helpful, and having them advocate for these programs because you're making a difference has really been helpful to set the right tone for the conversations. So I'm not sure exactly where we'll wind up. We'll wind up related to the amount of money that'll be put in, but thus far we've gotten good response from the key offices and a good support. So I wanted to make sure that you knew that work is taking place. Another bit of work that has been moving forward is we submitted our LBB report about a week ago. I think everyone has seen that. Again, shout out to our team for all the work to put that in place, and Lachelle and Jonathan and Luann and Nagla and Laura and the rest of the team here really put in a lot of hours to make sure that we try to communicate the work effectively and made it so that it was easy to understand. And again, thank you, Molly, and your team for the support as we put that together. But please take a look at that report. I think it tells a good story of the work and the variety of programs that we're putting in place. And again, really appreciate the support on that. We are having, there's a lot of interest related to the TCHAT rollout. Again, the message that we've been given is the desire of the legislature and the governor's office that it be available in every school that desires that by the end of this fiscal year. And that's a lot of work. That's a big lift, but we're seeing progress in that. We look at the progress every month. So thank you for submitting that data. That data is being transmitted to the governor's office, and it's being transmitted to the Senate Finance Committee and the House Appropriations Committee and other key offices. Again, they want to be as supportive as possible. In those conversations, we've told them that our main challenge is hiring the people. And that's been noted earlier in this meeting that, money can be made available, but if we can't hire the people, then unfortunately that money won't be used. But again, they've been very supportive of putting the money in that we need. And they're looking at those reports every month to make sure that we're making progress. And last little update from you is that last Friday, I had the opportunity to attend a meeting of DSHS. They have their initiative to improve hospital care. They had basically all the hospitals that provide births in the state of Texas attending. Probably had about 300 people there last week, and they asked us to present on Peripan. And good response from the group related to Peripan and the need, and a lot of support to make sure that it's not just a pilot in 4 areas of the state, but we come out of this next session and have the funds to make sure that it's statewide. And again, I got a lot of positive comments related to your work. They were pretty amazed with the number of people that CPAN and TCHAT are seeing already, and how that foretells hopefully the future related to Peripan and the difference we will make. So that's my little update. Any questions for me? And otherwise, I'm going to ask Lachelle, see if she has anything to update everyone on. All right, Lachelle, anything from you?
Just very briefly, just kind of an update on what we've been working on, other than the LBB report that took up a good portion of our time the last few months. But I think I mentioned last time we've been doing our site visits. We have now completed all but one site visit, and so the team is going through the documentation, the interview notes, the associated metrics and data, and we're consolidating all of that in a standardized view so we can identify where are the issues or challenges, where are the opportunities, are there areas that we need to look at standardizing. So we hope to pull all of that together for the February committee to give you an update on, what were our findings, and then start communicating some of that back to you individually. That will help us with our roadmap going into the next year. And so we're really excited to have all of this information that we're able to gather during the site visits. And I think we're going to see a lot of things coming out of it. So thank you again for hosting us, for giving us your time, and just been so great to meet all of you.
Yeah, and if I may jump in here, really, our team really does appreciate the support when they come to visit you. And again, the goal here is to is quality improvement. It's just to hear the great stories that are taking place, steal some of those ideas, share it with other institutions to make sure all of us are moving forward in the right direction. It's not to be critical or judgmental, but to hear and learn from each other and move these projects forward. And I'll tell you, the team comes back and they tell me about the great ideas, and can you believe this institution is doing this, and what a great opportunity, and this other institution is doing this other unique way to make TCHAT more available. And it really is good feedback. And we hope to present that information to you later in a more organized way as we're trying to help all of our institutions, understanding that a lot of your institutions can do things that other institutions can't right now, but there's a great opportunity to learn from each other as we try to move all of them forward throughout the state. The other thing I wanted to mention, the LBB report, for those of you that haven't seen it or are not on the executive committee, that it's on our website, and so it can be easily downloaded. And again, we want to make sure everyone sees that report that's interested in it, so they can, again, see the great work that you guys are doing right now. Any questions for Lachelle? All right, hearing none. And I think, Jonathan, you don't have anything to add, right, at this time? All right. Again, all right. Again, thank you very much. Let's go to the update on the collaborative care Meadows Mental Health Policy Institute update. Dr. Talibi, I think I saw you a little bit ago.
I'm here. Yeah. Hi, David. How are you?
Great. Good to see you.
Yeah, thank you for the opportunity to give a little bit of an update on our pediatric collaborative care endeavor. We have just a few slides to share. If we could pop those up, that would be ideal. Please and thank you. We can go to the next slide. Thanks so much. So a little bit of a temporal overview of what we've been focused on. Some of our recent accomplishments back in November and this month, we had our HRI-wide collaborative care meetings. This is where kind of representatives from all of our different collaborations join together for both technical assistance and situational awareness on kind of what's happening across a lot of different dimensions. In November, we submitted our second ARPA monthly report, gathering all the data. We'll share that in just a second. And our monthly meeting poll we put together to get feedback and a little bit more of targeted insights relative to what different HRIs and some health systems, actually, knowing that they're internally affiliated with our HRIs, would like to be spending their time in these monthly meetings really focused on. That was really insightful and very helpful, and will kind of inform what the meeting structure, including breakout groups, will look like in the coming months. Some resources that we put together on the technical assistance front include an overview document, a living document in the way of a frequently asked questions sheet that continues to expand based on feedback we're receiving and continued questions from different HRIs. We put together a usual care versus collaborative care document to really highlight, most often for executive leadership at different sites who are not familiar with the collaborative care model, of the various benefits across clinical, financial, and related domains of the collaborative care model, particularly as it shifts over into pediatric as opposed to prototypical adult populations. We've also met and discussed with different HRIs the pediatric collaborative care implementation milestones, both with what the benchmarks would be for getting the model up and running at a particular site, as well as what types of TA would be correlated and provided at those different longitudinal time points from the Meadows Institute. In addition, we've talked to folks about options available to them in the way of partnering with a vendor, i.e. buying some of these collaborative care services using those implementation funds versus an internal build. I'll share that based on a poll that we pushed out to our different HRIs, almost everybody is interested in internally building, which is not a surprise considering often this is really about shifting over existing faculty and personnel to be able to fit these roles in the collaborative care model. So what's on the horizon? Up next, we are in just a few days here pushing our December 15th monthly report, and folks will be providing that data in the coming days here. At the end of January, we are holding a pediatric collaborative care roundtable. It's the first of its kind. We're bringing pediatric researchers, academicians, and clinicians who are actually putting the pediatric model on the front lines and have actualized that in real life. Bringing everybody together and really focused on a clinical discussion around best practices related to pediatric collaborative care across a lot of different dimensions. So we're really excited about that, and we'll have a lot to share with you in the new year as that pushes forward. Additional TA resources we put together include a compendium of sorts, a collaborative care training resource reference guide, and then updating that usual care versus collaborative care document for folks. And further down the line, we continue to recruit health systems in concert with our HRI partners, continue to provide those monthly TA opportunities, and that metric reporting will continue on as well. Next slide, please. Just wanted to give folks a bit of a visualization of what this internal build looks like when we're talking about implementation milestones for pediatric collaborative care. Won't go through all of these, but from a domain standpoint, we're really looking again longitudinally at helping folks get their contracting done in a discovery phase with leadership buy-in being key, that commitment, making sure we have clinical champions as well as executive leadership on board, and then moving forward with the decision-making relative to building versus partnering. What does the financial support look like? What does that on-ramping schedule look like across different dimensions as well? Team building would be the next bet at that point, whether you're building or buying. It's putting everything together and making sure you have the right culture in place with the right content knowledge, and awareness of what everybody's roles are and what they're going to be doing over time. And then fine tuning that workflow design and build over time to make sure the clinical billing, program evaluation, patient registry, all the different stipulations to be able to bill for collaborative care model are up and running. And then hopefully we get to a maintenance phase where everything is self-sustaining and the work is essentially completed and just moving forward with continuing to support patients and their families and communities. Next slide, please. A quick slide on our metric data as of the end of November. We have, based on the metric of individually reached, over 42,000 lives are now covered through this model, and health systems, we have 7 of them. And I'll remind folks that our first year goal was 50,000 individuals initially reached and 9 health systems committed. We are making great headway on that front just a few months in. This has a lot to do with a lot of people on this call right now. We greatly appreciate our HRI collaborators and partners, and know that as soon as we bring these health systems on, we'll be continuing to work to ensure that they have all the resources they need to successfully implement the model and make sure it's financially sustainable over time. Next slide, please. That's all I had to share. Any questions that I can support answering right now?
Very, very good. I have a question here, Luann.
Good morning, Dr. Talibi. How are you?
Hi, Luann. Great to hear your voice.
You too. Hey, I just had a quick question about that 42,000. Are those pediatric alone, or does that include adults?
They are. Thankfully, you made a comment many months ago, Luann, and we went back and kind of shifted everything to make sure we were looking at that really 18 and under range. We are collecting data for over 18 as well, and that number is significantly higher than 42,000, but we are really focused on making sure that we're identifying those kids and those teenagers in the kind of sticking with the spirit of the legislation that designed this.
Excellent. Thank you so much.
Of course.
Very good. Other questions or comments? All right. I don't see any. So thank you, Dr. Talibi.
Can I just add one little thing? Thanks, Honey. That was great. You know, I do think it makes total sense, by the way, that y'all are doing the builds internally. But I would really encourage people to think about some of these vendors to work with potentially. And the reason I would encourage you on this is because of workforce challenges. And I think that, you know, for these initial builds, for sure, you know, I'm sure y'all have like access to folks, and I think it's something for us to think about too, as the consortium as a whole, that we are, you know, really pushing the development of our systems in a lot of different ways. You know, the discussion earlier with Rishi's presentation about, you know, people being concerned that as we look at these different options for children's mental health services, we prioritize and recognize that we don't have enough people to do all of them. I think I don't want to, that's not necessarily get into the specifics on this, but we have been vetting multiple firms that are doing a great job on this, that have been operating for years in other jurisdictions, helping people implement not just collaborative care, but other strategies as well, multi-systemic therapy, other types of things. So please think about that, particularly as you grow, because you're going to have in your initial stages probably folks you can put in, but as you're looking out for scaling, you know, it's really something that I think we need to think about. And David, we probably also need to think about some protocols for how we discuss potential vendors generally, because we at the Institute have no interest in promoting the interests of any particular vendor. But there are an increasing number of folks out there that have existing networks and are interested in partnering in a subordinate sort of way, so that your networks could be in the primary and they could help fill in. They're extremely flexible. And the ones we're talking to as well, we're very leery of ones that are like trying to, you know, be in charge and pull your people into their networks. The ones we're interested in are ones that are about building the capacity of health systems and are kind of agnostic. They just want to be helpful. There's a range they can be helpful, and they're not going to push in a particular direction. So it's worth us, I think, having some general awareness of that as a consortium leadership group, but also talking about the protocols we would use for being able to share information about that. And we've done a lot of focus on that internally and are happy to work with folks to maybe begin to draft up some protocols for for what is the right way to make folks aware of these potential partners, many of whom are commercial entities and for-profit entities.
Okay, no, happy to have that discussion and talk to David Lean to make sure we're doing it right. And again, we want to make sure we build out the programs, make sure we do it in the way that we all feel comfortable with. So thanks, Andy. I appreciate that. Yeah, that sounds like a good opportunity. Dr. Vo?
Yeah, I just have a quick clarifying question. The 42,000, that's covered lives, right? So how many are actually served thus far?
It's a great question. So the metric of initially reached was very deliberately placed in there to talk about the extent to which those are the lives covered by health systems who have agreed to participate in this initiative. At this point, there are no individuals being treated by pediatric collaborative care models in any of the sites currently enrolled in this initiative. And our hope is in the coming months, we will get that up and running very, very quickly. But this initially reached metric is pretty broad, and it's really meant to highlight how many individuals could be receiving these services when they're up and running.
And honey, I would just add that, this is Andy, Alex, on that one. Part of why we want to frame it that way too is the health system as a whole. This is a population level intervention. So the idea would be, even when it's fully operating, you're going to have maybe, 2 or 3% of the primary care population, possibly higher, that at any time are going to be accessing collaborative care services. But the idea is you're really bolstering the whole health system because now you have that option present. You have an evidence-based option to be able to build out. So there's different levels of questions we're trying to answer through the data. And this one is really, what is the potential population level impact across children? There are additional metrics that we'll be reporting on that get to the individual level impacts.
So when do you foresee adding that kind of data of actual serve? Because I think it's fine to have that potential right now because you're just getting started. But at some point you need to transition into how effective the actual program has been by looking at the actual numbers of patients served, correct?
Correct. There's a timeline, I think, where we have those different metrics falling in. And it's just basically based on the implementation progress. It takes about 9 to 18 months for a practice to kind of ramp up to fidelity at these levels. So, that will happen as the pipeline comes down. Do we have a schedule for that, honey? We can share with people. We do, don't we? Have a timeline on that?
We can absolutely circle back and bring that to folks if they'd like to see kind of what that looks like longitudinally.
I think all the projects have those. We're happy to share the one for this project.
Very good. Dr. Wakefield. Sarah, good to see you.
Nice to see you. I just wanted to kind of circle back to Dr. Vo's question, because I think this is something that we wrestle with a bit in some of our health systems improvement projects. And I wanted to make the comment that collaborative care is very much, in my opinion, like CPAN, where the impact is much greater than the patient served. And the patient served is important to capture, but it's really the model is this learning environment for the clinician that's participating as well. And so each person who's served, we know that there's this learning that happens in that, and the impact is actually exponential above and beyond that. So it's very difficult to capture, but I wanted to remind us all that that happens both in CPAN, in some of our educational efforts with TChat as well, and then definitely will happen in collaborative care. And so we can try to think about how that might be catchable, or how we can express that through the data, but that sometimes is difficult to capture in the patient served model.
That's a really good point I want to address since you mentioned me, Sarah. I think it's really important to not only assess the number of patients served eventually, but your point was well taken. Some of the ways I think we could actually measure that, and this could be implemented in CPAN as well, as how often, once that learning has been imparted, I guess, through the intervention, how has these providers implemented future, techniques or interventions with their patients? I think that's another metrics that that we could actually assess down the road to capture that learning piece, and then the implementation and the workforce multiplier piece that I think you're mentioning. So,
Andy, I saw your hand up, but can I just make a?
Yeah, please, sir, go ahead, and then tell me whenever you're done. Yeah.
One of the ways that Massachusetts has captured that, at least in the MCPAT for Moms program, is they have this beautiful graph that they show the increase in complexity of consults. So their volume actually didn't go down, but the complexity of each consult and what was being handled in that primary care setting went up. And I think that is really a great way. I'd love to start collecting that across these different programs, once they're up and running, because I think that demonstrates that we are actually building significant capacity in the primary care setting.
I love those. I guess I just wanted to say this discussion is so important because I think another structural goal of this program was really to embed awareness and expertise of these primary care based models deeper into our academic medical centers. So to have more HRIs aware of this, more faculty aware of this, and what we're hoping, and I think you'll see this, those of you who are participating in this pediatric summit that we're hosting in January, that we've had so many people want to be part of the, not just in the state, but nationally, because we're bringing in national partners on this, because we want folks who've been doing this at larger scales to contribute to the discussion, that we're not going to be able to have everybody there. So there's a lot of interest in it. And the idea would be, once we're up at this level of scale, Texas will probably have the largest academic center-based demonstration of pediatric collaborative care in the country. And to be able to do research, to be able to do that, I think there's a ton of wonderful research opportunities here. And so the idea is, Alex, you're talking about, Sarah, that you're talking about, that hopefully other people are bringing in. I'm hoping that not only do we, sign off on whatever metrics the federal government needs to show this money was well spent, let the record show, but also to really further our understanding of these models and look for additional leverage points. So I'm really glad we're having this level of dialogue around it.
All right, very good. Good dialogue. Again, it's important for us to measure what we're doing, and so we can tell the story. And again, it'll take us a while to figure out exactly what those metrics are, but we're moving down the right path. So again, thank you all for that conversation. Why don't we go next to Dr. Trivedi and the update on the Youth Aware of Mental Health initiative.
Thank you. Can I share, or are you, Lachelle?
Lachelle has the slides up.
Okay, so thank you for this opportunity. I'll go quick. Next slide. In fact, this is just a background to give you an idea of what this Youth Aware of Mental Health program is. Next slide shows some of the supporting documents that are provided in each classroom. Next slide. So this is the potential ISD student reach that we are really focusing on, and you have seen these numbers. So the reach itself is likely to be very big, and we are now beginning to get there. So next slide tells you that we now have, our original goal was to train 80 facilitators around, and now we have certified 92 facilitators across the state. Each HRI has YAM facilitators. They're already starting. There is actually this slide, additional facilitators being trained in December is like this week. So we have a whole class right now getting trained. But the big issue is all of the HRIs, participating HRIs, have trained facilitators, and they have made contact with schools. Next slide. And
Dr. Trivedi, just one quick point. As you're going through today, just you may not be aware, but there's a couple of new people that are here from TEA, John Scott being one of them. And so they may not be as familiar as the rest of the group, but could be really important in this conversation. And so just, as you're talking, just that there may be a few more details you want to give than may be obvious. Thanks.
Thank you very much. And so, yes, very quickly, and that was the first two slides. It is basically a 5-session interactive program. I think Julie is aware of it, Julie Wyman. So hello, Julie.
I am. We met a few years ago. You came to
Yeah.
TEA when you were launching it. Yes, sir.
So it is based on experiential training rather than didactics, and the students basically entire classroom is actually getting it, and it's not identified students, but the entire classroom. The facilitators are designed by design, not the teachers in the classroom. So these are independent new people. They can be from the school staff, but then it would have to be from another school rather than that same classroom. And the biggest task for us when we started, and continues to be for each of the HRIs, is to get engagement from schools. And so therefore, it is not just the superintendent or the principal or the counselors or the teachers. It has to be multifaceted. And we've done a whole lot of sort of learning modules with each of the HRIs so that these engagement with the school is multi-level, because then that we can go in and get these 5 classrooms, and you can see some of the examples of the schools that have already memoranda of understanding with each of the HRIs. I couldn't put all of them, but we are now really rapidly ramping up at each of the HRIs. Next slide. You can see this, each HRI that is participating has several big ISDs and small ISDs, all having memoranda of understanding. So they are really in these schools. And once you go to a school, it is actually very interesting. What we are finding out, for example, is that we were doing this in Irving and Plano ISD, which are the biggest ISDs around here. So Arlington ISD, which is very big, they heard about it, and so they started wanting to do it. So this word is spreading actually. And in fact, we are now getting a number of the LMHAs wanting to find out if they can train their staff. So we have to now think about how best to spread that. But right now, it is the HRIs doing it. And you can see these, all of the HRIs have actually now functioning MOUs with these schools. Next slide. So for this fall, remember this was just starting up. A lot of the school HRIs still didn't have the funds yet initially, but thankfully we have now been in 17 schools, 120 classes have been actually engaged already with 2,100 students getting this in the fall semester. 4 HRIs have provided YAM in over 15 classrooms. Lubbock and UT Southwestern have been actually at the forefront of this. Dr. Wakefield and her team got trained actually last year. So they have been doing it, and now multiple schools will start in the spring of 2023. Next slide. We have now created websites, a dashboard for each facilitator to keep track of the schools, how many students they are getting into, and we can then keep track of it. There is also an ongoing monitoring and quality check for the instructors. So it's not just a one-time training. It's a very rigorous 5-day training program that is very well orchestrated by the developers. So they actually, we now have a number of trainers we have already at our training academy created so that we can now do as frequently as we need the training for facilitators around the state. Next slide. So we are also getting quality data for at least the students to get a sense of what is it we are doing, because we want to be able to show impact. So if you look at the next slide, we are getting data related to demographics, resilience, some screening only, not very detailed measurements of depression, anxiety, but still screening, peer family relationship, mental health literacy, help-seeking behavior. These are the domains that the developers have shown, we have shown and published on this, that are impacted by this program. Next slide. So give you an example here. If you look at on the left side, I have a clear understanding of what may cause mental health problems, and you can see completely agree numbers dramatically increase. Same thing on the right side. I believe I know where I can get help if I ever experience mental health problems, also increases. And this idea of awareness as well as help-seeking behavior are the ones we really want to impact. Next slide. The good news and and some opportunities we need to start as a consortium, start thinking about. If you look at just these two questions on the PHQ for this, remember, these are all entire classroom. You find 17.2% of kids report significant difficulty with depression, and 23% report significant anhedonia. That tells us that I think we will then need to start thinking about what else to do with these two students, because right now that is not the goal. We are just doing this 5-session program. Next slide. And we are seeing the same numbers in terms of anxiety symptoms. So there is a significant amount, and this reflected in CDC data, national data, that about a quarter of the students really have significant anxiety and depression. And I think that we will need to think about as a consortium how we go forward with this. Next slide. But we have shown in our work before we started this statewide initiative that just the use of this program can reduce depressive symptoms and anxiety symptoms. So that really is, at least as a first layer, tier 1 intervention can be seen. Next slide. There are wonderful student stories that come up, which is they came when I was struggling myself, so it's a perfect timing. I also like the book they gave us because I think it may be helpful. It teaches you about mental health, really is. It teaches us things about health and what can cause stress, and school doesn't do that. How comfortable they allowed everyone to be while talking, and their relations to everyone who struggles. So you can, these are all in the slide set you can read. Next slide. So our goal is to continue to expand, work with each of the HRIs. I think that the engagement part is where we are still focusing with a lot of HRIs, but it's improving quite a bit. Next slide. We have also published a number of papers from the previous work, and now this collected data that we're collecting will actually then go forward with publications as we move forward. Next slide. I'm going to stop here, but open up for questions. Happy to answer any questions.
All right, very good. Carol, I see your hand.
So I just wanted to comment first, Madhukar, and thank you for such a clear presentation. It's so great to see this program grow like this. My question is to you, David. Will this YAM program contribute to our promise to the legislature to involve schools, to contact schools all over the state, or is that specific to TCHAT?
Yeah, I think they're different conversations. The direction we've been given is with TCHAT to make it available to every school that wants it. And so that's a different metric, so to speak. I think this is very supportive of trying to improve the mental health of our kids in the schools, but the direction from the legislature has been focused on the TCHAT and making it available to every school.
Thanks.
Mm-hmm. Brittany, I see your hand.
I just had a quick comment about how much we love this program and the positive response that we're receiving in Tyler to some of these smaller schools, and having this. It's such a lovely program adjacent to TCHAT, and I believe having our programs with TCHAT has really helped us gain interest, already having those relationships with some of the schools for them to sign on to YAM. So I think it's great. And I think, while it may not be a requirement, I certainly think TCHAT will help this program spread.
Yeah, very good, Brittany. Thank you. And thanks for all the work you're doing out in East Texas to make it available. Luann?
I just also want to say that TEA hosted the ABC Summit a couple of weeks ago. And as a result of that summit, Jeff Carr from Texas Tech presented information about what they're doing out in Lubbock. And he did talk about the Youth Aware of Mental Health program. And as a result, I think I must have flooded Dr. Trivedi with emails from across school districts who really want YAM in their school. So the word is getting out, which we really appreciate. Thank you.
And thank you, Luann, and keep the emails coming, no problem.
Julie, I see your hand.
Yeah, I just want to double down on what Luann said. It's a joy for me to see Dr. Trivedi, be able to launch this. I saw the early data from the pilots and the research, and I can see the uptake is going to be strong. It's marries so nicely, like Brittany said, with T-Chat as well, when you can layer this in, and what Luann said that Jeff Carr presented. There's so much you all can do as this consortium to wrap around our schools with mental health and all the partners, that it just brings a lot of joy in this holiday season to hear this is happening and to see your slides today. Thank you, Doctor.
Thank you.
All of you.
Thank you, Julie. That was very kind. So thanks.
And I'll make sure your kudos get passed on to Jeff Carr. Thank you.
He did a great job.
Yes, he did.
All right. Any other comments or questions? Hearing none, Laurel, Dr. Williams, we're going to transition over to you for the update from the COSH.
Okay, thank you. Hope everybody's having a good December so far, despite the fact that it can't decide what temperature it wants to be. Except hot. I guess it is Texas. I'm just waiting. Do you want to do this? There we go. So we just thought we'd start with a little Christmas cheer. She's already passed by. I can't read that fast either. So we're moving from Thanksgiving to Christmas, and I want some carrot cake. It's lunch. We're ahead. We're in front of lunch for you guys, so we'll try to make this brief. I think it will be. Next slide. So we're just going to give you sort of some amuse-bouche, some highlights of CPEN, PeriPen, and T-Chat for as we close out this sort of year of December. So we're in December 2022. I cannot believe that it's almost 2023. So next slide. And again. So we actually just wanted to kind of go back in time. This is often a common pastime for us in December and January's of each year, but we just wanted to show teams to that point that was made earlier, all the good work that all the HRIs are doing across the state as it comes to working within, this is for the Child Psychiatry Access Network, of course. But you can see here that we've had over 63% growth between this year and last year when it comes to our CPEN consultation. That is, again, directly related to the hard work of each of the individual HRIs, the work that the communications team has been doing to help us sort of develop our statewide strategy and messaging and honing in on different kinds of ways to engage in outreach, the PCPs, the pediatricians, the family docs, the work with TPS, and so many others. But we're really excited to see this graph kind of show us that the work is continuing to gain traction. And time and time again, Dr. Tran, who is our pediatrician, helping us with CPEN, again, she's just hearing consistently positive responses from physicians across the state, providers across the state when it comes to what CPEN can do for us. So we're just excited to see this growth. And we anticipate in this 2023 that we will see another kind of pretty nice and steady increase in the number of care consultations we provide to pediatricians across the state, and we're just excited to see that number. Next slide is actually looking at the dashboard real quick. So this is kind of give you a sort of a view of where we stand in December of 2022 when it comes to the number of providers in our state who have enrolled. I'm just waiting for Edith to be able to make that switch. So ooh, somebody has Dark Side of the Moon with a brain. That's cool. Particularly, I like that. Edith. Let's do the Jeopardy song, if anybody remembers it.
Sorry, it logged me out.
It logged you out, so protected, yeah. I don't remember the numbers off the top of my head, so I cannot rattle them off. I definitely need things in front of me to do that. So we'll have to just. There we go. So one of the things that we do want to point out, we're not going to share with today, but we actually see at the very top of the dashboard. Hello. That you can toggle between both CPEN and PeriPen now. So as we start to have some additional information, then Dr. Wakefield can walk you through the PeriPan dashboard. But we're sort of that dashboard is kind of being built out. So it's not quite ready for us to show at executive committee meeting. Nonetheless, as you look at the number of providers that are in our Texas CPAN program, if you hover over that number 9792, you can see that this is the total number of providers across the state who've completed the agreements. This includes pediatricians, family physicians, as well as residence physicians, NPs and PAs. We're in over 1,800 clinics, and to date, we've completed over 15,000 consultations, and we are continuing to do well with, if a pediatrician, a family doctor wants to talk to us within 30 minutes, our response time, as you can see here, median response time is 6.3 minutes. So we do understand that one of the questions based on that earlier feedback from the external evaluation team is trying to help doctors understand how this works in their day, like how to put it into their workflow. So a lot of the work that we're doing with the communications team is to talk about how we can help with giving that information and knowledge and training to pediatricians, family doctors, so they can see how, although yes, you do need to put in your workday, it actually improves your workday and potentially make things flow better for them. But that is definitely still pretty good response rate that we can get to them as they need that. As PeriPan does get going within the region, we'll also start to, as I said, when we show the dashboard, we'll show some of that information, but I'll leave that for Dr. Wakefield in a few minutes. If you circle back down to the middle part of the graph, so you can see here, again, this is just the look back for the last 6 months. That's why I wanted to show you that other slide that had the sort of 12 months data on it. But again, we are continuing to just go up and up in the right direction. And when you look at the staff engagement, on the next bit of the slide, this is the last one, hover over there we go. You can see here that, 52-53% of our callers are people who've called before already. So I do think that this points to the usefulness and efficacy of the program, that the providers call once and then they like, yes, this is helping me, and call again. As you can see, the clinic staff roles, overwhelming majority of people who call do continue to be the physicians, but certainly the nurse practitioners, as well as counselors, other clinical staff, and like resident learners themselves can call. So we continue to see pretty significant amounts of physicians calling on behalf of their patients, even though we've sort of talked with the physicians about how you can have some of your other team members assist. It still is the vast majority of the time they're calling for themselves. And if you go down to the next start of it right there, we can see here that again, 97% of the time, the physician, when they call, they're calling about a specific patient. They're requesting assistance with not just referrals, but also from a medical standpoint, what to do, how to get maybe to a proper assessment, proper diagnosis, proper treatment, and 25% of the time they're asking to speak to our child psychiatrist on the call. So that's kind of where we have that for CPAN. So we'll go ahead and move back to our slides. So just going to be brief. Just toggling back and forth. All right. Next slide. I think we're handing it over to Dr. Wakefield. So Dr. Wakefield.
Yes, hi, excited. So Molly made reference to this earlier that we do have some data. So we're not going to view the dashboard at this moment, but we have pulled some data that we have. And so this first slide is on PeriPan OB enrollment. And if you hearken back to the beginning of CPAN and remember that we really focused on pediatricians and family medicine clinicians to be our metric over time for enrollment. And we have done the similar thing in PeriPan to focus on those OBs. It doesn't mean that we're only enrolling OBs. We had nurse midwives and psychiatrists, PAs, nurse practitioners, pediatricians, and family medicine physicians as well. So we have that data and we are enrolling those clinicians. For those who already were using CPAN services, we have task teams and they have done a fantastic job in our pilot areas about notifying those pediatricians and family medicine docs and clinicians who are already enrolled and utilizing CPAN of this new service, this new expanded capacity that we have, to also talk with them about their patients and moms who are pregnant or postpartum and suffering and about whom they have questions. And so this data right here represents the OB, the obstetrician enrollment. So you can see how we've increased this over time. We did set a metric for the end of October, having 25% of the obstetricians in the pilot areas enrolled. And we did meet that metric, which we're really excited about. We have set some new goals for the coming year, and we're excited about those, but wanted to show that we have 28% of the obstetricians across the pilot regions enrolled already in PeriPan. So we are very excited, very appreciative of the HRI pilot sites for all of the hard work that has gone into making this possible, all of the presentations that have been given to talk about what PeriPan is and this new expanded population that we are able to serve through an access project like PeriPan and CPAN. Next slide. So you can see we already have clinicians who are calling PeriPan multiple times, and we're really excited about that. We are looking at some of the consult activity specifically, and what is being asked about. We have had a couple of calls about emergencies. Again, we're not an emergency line, but sometimes people do call for guidance in how to assess an emergency or where to go next. So we have had a couple of those calls as well. About 40%, 42% are about asking a psychiatrist to call back about medication related, and then 65% for referral requests. So where can I send this mom for treatment? And then we have 82, almost 83% about specific patients. I think this gets into Molly talking about looking at this data overall. Are the other 28% or 18%, if I can do math, related to enrollment for PeriPan? We'll get some more granularity around that data. One of the things that I wanted to talk about here is that we have also, many of you are aware that CPAN, we've been doing a pilot through CPAN for direct face-to-face consults. And what those of us who treat women knew and expected, and some of the discussions that we've had with Lifeline for Moms, who we've really sought a lot of consultation in development of this program, the PeriPan program, is that there's a lot of complexity around diagnosis for many of the women who clinicians call in about. And so sometimes we do need more diagnostic clarity before we can give really clear guidance on next steps in treatment, even though it would still, in many times, be appropriate to have that treatment done in the obstetrician's office or the family medicine doc's office, or in that primary care clinician office. So we wanted to, and have discussed this with the HRIs, that several of the HRIs in the pilot are able and have been participating in the CPAN direct face-to-face consults. And so talking about the ability to launch that as a part of this pilot project for PeriPan as well. So we'll be continuing to discuss that to meet that need at the closer to the outset of this project, and working on that pilot wide to see how we can facilitate that if we have the opportunity to go statewide in the future. Next slide. And wanted to talk about this educational series, again, mimicking many of the things that are done with CPAN. That one thing that we've really heard great things about is the ECHO series and webinar series that is delivered through to our CPAN enrolled clinicians about children's mental health, education, about etiology, epidemiology, prognosis, and treatment strategies. And so we are developing a similar educational series through PeriPan that will be delivered in concert across the HRI. Some of that webinar content will be available statewide to all clinicians, whether or not they are in a pilot site. And then some of the content in those echo learning communities that are really designed to be smaller, group-based, continuous learning communities will be developed in those HRI pilot sites. But we will have a webinar curriculum and an echo curriculum that the clinicians who are engaged on PeriPan right now, those reproductive psychiatry and psychology experts are helping and contributing to developing. So I cannot express my gratitude enough for all of those volunteers. I think we have some really great content coming and will be able to be delivered, like I said, some to across the state, even prior to any statewide availability of the service, and some in those specific HRI areas and those smaller learning communities. I think that is it, but I'm available for questions if anybody has any.
I just want to add that for CPAN, we are been working with the internal evaluation team to sort of have the vetting process for the providers across the state of Texas, so that we can start to tell the executive committee and the larger community what percentage of physicians, specifically physicians, primary care, pediatrics, family medicine, what percentage of them have enrolled in the service. All of the teams had to do a pretty extensive review of sort of their own vetted list, turn that in a very specific way to David and Molly at the internal evaluation team, and they have been working through that process to do their own cross-check. So once they have that available, then we will start to share that information for CPAN as well. For some of the ARPA projects, particularly the direct consultation, we did do, as Sarah said, not suggested, she said, we had sort of completed and finished up our direct consultation pilot. We are reviewing that information and lessons learned from that program, from that pilot with the CPAN leadership team. And once we have sort of all the information sort of compiled and put together, we'll probably present that. I think what I'm hearing is in February, in the February executive committee, so we can talk about that particular process. As far as one of the ARPA projects, we already have available for providers to use the text messaging, and that process is running. It's we don't get a lot of our consultations through direct messaging, but it is certainly available for providers to do that. And that's the way to start the consultation. It's not a back and forth conversation. As far as it's more of a, hey, I'd like to have a CPAN team member reach out to me at a specific time, because that's when I think I'll be available to talk about the patient. So it's really, again, us trying to help sort of move and make CPAN be easily reachable and available to providers in their busy clinic days. So you'll hear more about the direct consultation pilot and its outcomes and recommendations in February of 2023. Moving on to T-Chat, as we can see.
And
Yes.
Laura, before you do that, I see Andy's hand.
Oh, sorry, Andy, I can't see hands.
Yeah, no worries. There's a lot going on the screen. Thanks, David. And it could be fine later, but I just wanted to, just before we get too far past Dr. Wakefield's presentation, I hope that our process measures are getting at this, because I mean, just think back, y'all, when we were first thinking about how to start enrolling people in CPAN, and we're like, what do we do? Like, how do we do this? And like some folks were able to run with getting folks enrolled, other folks, needed help and all, Sarah, the way you presented that, like, as you all know, the first step is enrolling people, and the progress is extremely rapid in just 3 months. And I think like we know how to do this now in the state of Texas. And I think this is a really important structural capacity that we now have as a consortium to roll out other models. And I think this just, I hope our process metrics capture that, because the structural capacity of this organization with additional partners now formally through TEA to respond to emerging and priority needs is a really important thing. And we should just have at least a small feel-good moment about that. So anyway, that's it.
Thanks, Andy. No, it is really exciting. And I can't say enough how when we were giving presentations about, how to engage, because some of our peri-PAN teams are the exact same as our CPAN teams. But we brought on a lot of new team members, and HRIs engaged a lot of new team members too. And so we were able this go around to pull all of this information from the Center for Healthcare Communication work that's been done, really give some upfront guidance, PowerPoints on step-by-step what worked in CPAN, what were our greatest strategies. And I know all of those things went in to the ability to really rapidly engage and enroll clinicians and busy clinicians. All clinicians are busy, but our OBs are extremely busy. And so really excited about how effective our teams have been in this enrollment and engagement process. And I do think that it is because of all of the work of the consortium that we were able to really lay out a succinct, clear plan for an enrollment engagement strategy.
Yes, I absolutely agree. I think it's been so instrumental, as I said earlier, the communications team, Laura and Melanie and the group and that they're working with really helped sort of fine tune that so it was ready to go when peri-PAN was launching. And so I think to your point, Andy, Texas is definitely, we've always been on the map, let's be honest, but we've been more on the map, and I think we get a lot of interest outside of our state about how we're doing things and wanting to learn. So I think thank you for letting us pause on that as we have a moment of just like, yes, this is what we've done. So we're pretty excited about it. Other questions? It's like, I can't see things. No. T-chat. Moving on to the next slide. It's a beautiful slide that doesn't say anything, just slide. Maybe. No. Sorry, I don't control the slides, so. Rita?
We're here.
There we
There
go.
they are.
Okay,
Good.
there's some technical difficulty. It's why I let other people do it, so I don't have to stress about it as much. So again, just like we did with CPAN, we just wanted to kind of show sort of an overview of 12 months of worth of data, because CPAN was based on an academic year, a calendar year with January to January. We wanted to look more because it's more typical for us to think about school years as starting in August and ending in May, June. Even though our services do go through the whole summer, we don't stop services for TChat because it's summer. We just get creative about where we're seeing the kids. So as you can see here, the blue line is our academic school year from last year, the number of referrals that we've received. The red line is the 4 months to date that we have from the data for this year for the number of referrals that our teams are getting across the state. And this is about over 60% increase in the number of referrals last year from this year. So we're certainly seeing continued growth as the HRIs again do an amazing job going out there, getting to school. So there's so many steps that are involved, to Andy's point, Dr. Keller's point. There's not just one step involved, and it's not kind of a one and done when it comes to onboarding these over 1,200 ISDs across the state. You first have to engage, you have to explain, show them about the program, talk about its benefits, have that school district make decisions. This is something they want, don't want, start the legal process. And then after that even is done, there's still additional steps of training the staff, going and making sure that there's all the things that need to happen to make an appointment occur. So there's a million tiny steps that get to that point of even having a referral. So there's been a massive amount of work that has been done at the 12 HRIs. And it's, again, if you go to our state website and look at that coverage map that the internal evaluation team has created, it certainly is telling a story of growth across the state. And we're all very aware of the goal that Dr. Ricky has set and that we've set for ourselves, I should say. So we're very excited to see this referrals. Next slide. The next slide is actually not looking at referrals, it's looking at actually individual sessions. So this is not about a unique patient, it's about the number of sessions per month that are being done across the state for TChat. And so as you can see, again, looking at the school year starting of last year in 2021, I want to point out that in June, July, we are not shut down. We are seeing kids. So even during the summer, our teams are busy. And so as again, we look at sort of how we're doing this school year to date with the number of sessions provided to students across the state, it was an over 9% increase in the number of students from this year to last year. So we are definitely, the teams are busy, and we're happy to help the kids and families in the schools. But we're certainly seeing a lot of growth, and we anticipate we'll continue to see growth. I want to stand with this one for 1 second because Molly had talked about the Columbia Impairment Scale, and we have built into our process and sort of doing work with outcomes and measurement-based care. So our program actually can allow for us to capture information related to individual diagnoses and track things over time. Actually, the data committee that Dr. Pliska chairs is reviewing some data around some early information, and that information will be forthcoming in future meetings when Dr. Pliska has, the data committee has felt like that data is ready to share. But it is specifically looking at outcomes related to disorder specific. To Molly's point, we have already built in, it's already built into the system now, the Columbia Impairment Scale. What needs to happen next from a process perspective is making a final determination about what time points do we want that particular scale to be used, which team members at each HRI can do the scale. If and when the family can't do it themselves, we can have a team member ask the questions and get the answers to them. So we do hope that sometime in the early spring, we'll have that sort of process finalized as well. So we can start to, as Molly said, track not just at the symptom level of disorders, but at the impairment level with that Columbia function scale. So we're excited to see that. And we'll be excited to see the data that the data committee feels is ready for people to see probably sometime in either June or probably the February meeting would be my guess. So you'll see some of that outcomes related data. Because we do think that using measures to measure how we're doing is going to be as important as how many students we have seen. So that is coming down the pipe. Next one. That's it. I told you brief.
Thank you, Laurel. Pretty impressive that we're approaching almost 5,000 sessions per month through TChat. That's a, those are big numbers and continued growth. So congratulations to everybody. Andy, I see your hand.
Yeah, just again, I mean, same point, David, really well said. I do think, question, Laurel, on the outcomes, which I'm really excited to see, and I do agree that having those functional outcomes will be nice for our initial phase. Have we thought about over time how our measurement-based care infrastructure, where we, because while functional outcomes are nice, they're not necessarily all that helpful for, knowing how to treat specific conditions, whether it's depression that's driving the issues with the family or whether it's anxiety or trauma. I mean, do we have a kind of a vision over time about how some of that, more diagnostically related measurement-based care infrastructure may fit with our outcomes? And again, this is more, I think, for our development over time. It's not something I think we need to demonstrate to outside entities, but I think it's a tremendous strength given how rigorous the implementations have been, particularly at some of the HRIs. But I mean, is that a dialogue?
Yeah, so we do have several measures that are already been discussed and teams are using. So we're using the PHQ-9A. We're using the SCARED. We're also talking about whether or not to do the SCARED versus the GAD-7, which is also something that we have access to. We have also the scales related to review of PTSD as well as anxiety, as well as ADHD and ODD. So we have a number of measures that have already been created, are available to teams right now. What we've actually been discussing is sort of the setup of how to determine the how and the when to use them. Even though TChat is a statewide program, there are 12 different, to some degree, 12 different sort of processes for how teams are running their TChat programs. So for me to do the PHQ-9A with my team in one way may not be exactly the same way that another team and another HRI needs to do it. So we are talking through how to do that. And when I talked about earlier, the data that we have that Dr. Pliska's data committee is reviewing and looking at is actually the PHQ-9A, because we actually have a pretty substantial number of students who have done repeat measures of the PHQ-9A. And so that they're doing some review of that data and the analysis of it. And so when that's available, Dr. Pliska is going to present that and from the data committee. And sort of, I think to your point, we're going to start to see that. So we do want to use the measurement-based care to also just actually improve the care. So again, making sure it's not only that it's a checkbox that somebody did a PHQ-9A, but really if the PHQ-9A is telling the providers something about the care, that we want to make sure that they're using it in that way to make the care be better. So that's the piece. We also are envisioning to some degree how this is going to connect back to CPAN. And so that, again, if we're all potentially kind of agreeing that we're using similar measures and we can kind of help train and coach the primary care physicians to be using the same ones, if we can have that discharge summary from TCHAT go directly to the CPAN provider, pediatrician, they can see what measures were already used, what the outcomes were, and so that if they continue to see that kid in primary care, as we've been working to do with TCHAT, then we can sort of keep tracking even more longitudinally how that young person is doing. So we do envision a way for having even CPAN and TCHAT to be connected in those kinds of ways with measurement-based care.
I just think, Laurel, it's really cool to have that dialogue. I knew y'all were doing those things. I just think for us to understand, again, this is a pretty amazing infrastructure for being able to advance our understanding of things that really, not a lot of folks have had insights into at this scale. So I want just on the record that y'all had done that, because I think it's super impressive, and it's going to help us get even better outcomes.
Dr. Wakefield?
Yes, I wanted to bring in the point also that we've had extended discussions because we have an entire measurement-based care committee through the Youth Depression and Suicide Research Network as kind of the learning health system that we're trying to, what can we give back as well. And so developing measurement-based care modules that would be accessible for primary care clinicians so that we can really standardize some of the education and around measurement-based care. We have done this already. We have videos out there, but trying to make it even more accessible if it's modular, module based so that people can click through it a little bit more quickly. But trying to think of, and Andy, I think this is such a good point about we try as the consortium to look at all of these different points, like what are the gaps, what are our expertise, how can we help contribute to this? Because if we are going to be wanting primary care clinicians to utilize the same measures as we're using so that we can tell this story over time for these children and make sure they are improving, we also want to make sure that the primary care clinicians know how to use these measures. So if we're already providing the education, if we're already doing that, can we replicate that and expand that footprint? So lots of different conversations about how we can help all of these different projects and fill in the gaps with what we're already doing with the consortium in different areas.
Dr. Ibrahim?
Great presentation, and thanks for the discussion. I may have missed this, but for the behavioral health providers that we have, not the primary care physicians, are we using the measurement-based care tools as a requirement, or is that left up to the providers to use them or not?
For CPAN or TCHAT, I'm sorry.
Either, actually. I'm just asking, the question that Andy asked was for CPAN, it would be more complicated. The question that Andy asked, brings the outcomes up front here. So I don't know whether we are thinking that we would have some standardized set of tools where it would be an expectation that at a frequency that we will be doing these skills.
So for TCHAT, we have certainly been discussing it. We have not landed on something, but it's definitely been a conversation. There's been several conversations that we've been having around TCHAT as it relates to having a more unified approach. And I know Dr. Lakey is helping us think that through. And so yes, CPAN, I think it's a little bit more aspirational as to your point, how that is possible or not possible. But I think with the increasing work that the Meadows team is doing with the collaborative care model, and maybe some of these larger organizations that are participating in it, sort of, is there a way to have some energy around sort of, we're going to kind of agree to utilize similar ones that are kind of within these various places to point. So I think we're in very early stages for that when it comes to CPAN, but it's definitely been a topic.
Thanks.
Mhm.
All right. Any other questions for Laurel or her team?
Hey, Dr. Leahy, quick question for Laurel, and I couldn't get off of mute quick enough. But Laurel, how many HRIs participated in the direct consult pilot?
Edith, was it 5 or
6?
It was 6. 6 participated. 2 will be moving forward because they have ARPA dollars, and so they wanted to see the outcomes of that pilot. And so we presented that information to the CPAN leadership team this last month. There was some additional questions that the leadership team asked for us to kind of track down. And so we were not ready or prepared to present to executive committee the findings, but I think we'll be ready in February to sort of talk to the larger executive committee about sort of that process. And what we found, I should say.
Very good. Any other questions for Laurel? All right, I'm not seeing any. Thank you again, Dr. Williams. Again, a lot of work throughout the consortium. You know, those numbers are moving in the right direction. So again, that's a lot of work in your institutions. We just need to continue to seek to hire the people we need and continue the work to continue to build it out into the other schools. So again, appreciate all the hard work to do that. So Steve Pliska, actually, before I go to you, Steve, a quick little check. If there's individuals that have joined us since we did roll call, if you could just identify yourself so we can make sure that you are, that we show that appropriately in our notes. Sonia, I saw that you're here today. Anybody else? Dr. Chapa? Anybody else? All right. Very good. Steve Pliska, let me go to you with the, if there's anything that you want to update us on CPWE that we haven't heard already today.
Sure. I think there's just 2 items on CPWE. One, David Lynch and the internal evaluation team are going to be initiating the resident evaluations for this academic year, and that's really critical. We're seeking to enlist the help of the program directors at each of the sites. So both he and myself will be reaching out if we're not getting response. We really want to increase our response rate over what it was last year. So that's going to be a key event occurring over the next several months, because we want to catch the people that have been on the July to November rotations. Secondly, we're continuing to urge each CPWE site to work with their LMHA on making sure the patient count data that's being fed in centrally is accurate. We have a concern that there's actually a bit of an undercount. Now, we're doing pretty well overall. You just look at the raw numbers, but that we may actually be doing even better. In terms of the impact and number of patients seen, and there's a lot of reasons this can occur. Since residents rotate, someone forgets to change the algorithm to pick up the new person who came on, or EMRs can change. There's all kinds of things that go on behind the scenes. But it's critical for us to get that data. So again, the internal evaluation team can combine it with the patient counts and patient session counts from the non-LMHA sites to get a true picture of the impact. So those are the main CPWE updates. Now, I can do the data management committee update as well while I'm on screen here if you want.
Yeah, let's go to that next.
Okay, as Laurel mentioned, we're looking at the data that has been gathered in TChat through the trait system. We're currently looking at the PHQ and the SCARED, which is the measure of anxiety. There is a very decent sample size in terms of baseline measures, as well as people who've had at least one follow-up measure. Abigail Kosh, who's the statistician for trait, has completed the initial evaluation, and we are working to kind of get the presentation in shape so that we're reflecting the findings. What I can say in particular for the PHQ-9, there's very clearly a statistically significant decline in ratings of depression over time as people are in the program. That is related to the baseline severity, meaning obviously that people with more severe depression or people who have ratings that are typical of those who are clinically depressed are showing the most significant decline. We also show equal degrees of improvement across all of the various ethnic and racial groups that we've looked at. And we're continuing to look at the the anxiety ratings and kind of refine that to see exactly what the finding is there. So I think we'll have very solid data to present at the February meeting, but we also will have that data available certainly by January 1 so that the central team can look at that and use it to talk to the public about the impact of the program. I think one of the good points was made here about measurement-based care. We don't have uniformity across all our TCHAT sites as to when and how often they do the various measurements. And we have logistical issues whether families cooperate with the measurements. So there tend to be a large number of baseline assessments, and then a decent number of one-time assessments a month later, but then they tend to drop off. So I think it is an issue for the data committee to puzzle over, and then ultimately the TCHAT leadership committee to talk about to what degree that should be standardized or mandated in order that we can kind of really get a full picture of the impact. And I think we're looking pretty regularly at depression and anxiety symptoms, but of course people are referred to TCHAT for a whole variety of other problems. And there may be some measurement-based care measures that would be appropriate to look at those problems so that we can see where the impact is there as well.
Very nice. Thanks, Steve. Any questions for Steve or Alex? Do you have anything to add?
Nope, he did it very well.
Very good. All right. Any other questions for Steve?
Well, no,
Yes.
but excuse me, Dr. Lakey, I'm sorry. I was dealing with an issue here at the clinic. I just heard you mention my name, but I was talking over here, so I apologize.
No problem whatsoever. I'm just wanting to make sure the record reflects that you're here. So
okay.
Just when we did roll call, sometimes people join afterwards, and I again just want to make sure that our record shows that they are here.
Okay, thank you, Dr. Lakey. I apologize again.
No, thank you. Any other questions for us? We've made our way through the end of the agenda, but again, want to make sure if there's any other issues that we need to talk about, consistent with the Open Meetings Act that we do, if there's any questions on your mind. Okay. All right. Well, I'm not seeing any hands raised. And so again, want to finish this thanking you all for the great work that you've done. Again, looking at those numbers, the numbers really are pretty substantial. Almost 5,000 TCHAT sessions. About if I remember right, you're close to about 900 of the CPAN visits per month. Those are significant numbers, and so again, appreciate that. In addition to the new programs that we're ramping up. And as I noted earlier, we are working with the legislature to make sure your needs are understood and as best they can addressed. We should hear, I hope, by January what the base bill is, and we'll share that with you as quickly as we can, and then go from there during the legislative session. But again, I'm very positive related to how they're receiving the work that you're doing and the current impression of the consortium. Again, Luann, you're noting at the Texas Tribune event, one prominent legislator talked about, unprompted by us, talked about the consortium and your work as one of the things that are going right. And so that's good when we have a variety of other people that are shouting out this work, and that lays a good pathway for us. We'll continue to update the governor's office on a monthly basis. And so again, we continue to need to get that data from you to make sure we're as up to date as possible in that process of making sure we get TCHAT into every school that wants it in less than a year now. And it's a big lift, but it's really important. And you guys clearly are on the way of doing that. With that, I think I'm done. Is there anything else from anybody else before we wind this up?
Happy holidays.
Happy holidays. Yeah, happy holidays. I hope you get some restful time, and we'll see you next year. Thanks, everyone.
Thanks, David.